Hello everyone. Here is Escola de Intensiva, UTI Papers podcast, and today we have our second international guest from the United States, Dr. Nick Gioni. We are really honored to have him here, and I'll pass the word to him for him to introduce himself. Today we're going to talk about a little bit of mechanical ventilation in some cases. Nick, really welcome. Thank you so much for accepting this.
Yes, sir. Thanks for having me. As he said, I am Nick Gioni. I also go by Palm Toilet on social media, most notably on Instagram at this point. Have a podcast, the Peak Inspiration Podcast, that's on sort of all the platforms. I am a pulmonary critical care physician. I did fellowship at MedStar Washington Hospital Center, which is in DC, and then I sort of stuck around there, and now I'm currently in Virginia at Inova Medical Center, which is sort of like a bigger hospital in Northern Virginia. We do ECMO, heart transplant, lung transplant, all that kind of stuff.
Awesome.
My sort of like I guess how we wound up here was for a while I was on sort of med Twitter, like back before. And then Twitter sort of started, sort of spurting out a little bit and wasn't as stable as a platform. So I wanted to do some vent teaching. So as a part of my fellowship, we have a ventilator course that we teach the fellows and the attendings like throughout the country, and we teach it in like a specific way. So we have to like take a test at the end of the year. It's like pretty intense. So this is how I sort of got started on Instagram teaching the ventilator, because it's like such a poorly taught topic, I think, in general. And just from you guys like Brazil, certainly South America, I feel like you guys have a much better handle on the ventilator, just like overall, than Americans do. Yeah, man, for sure. Like
Good.
when I see,
Interesting.
when I see you guys talking about it, or other people that I know are like from Brazil or from like other South American countries, I don't know what it is, but they just seem to have like a really good handle on it. So, I'm
Nice.
honestly impressed when you guys talk about the event. So I'm really happy to, talk about what we're going to do today. It's going to be awesome.
Nice. Thank you. So let's go through it, and we're gonna go through some cases just to. I think it's more practical and easier
Yeah.
for us to start the discussion. So let's see. Imagine you are in the ICU and you have a 41 years old obese patient intubated 2 days ago with the diagnosis of pneumonia. And to start here, let's say, what are specific points during ventilating this type of patients that you need to be aware setting the ventilator? What are things that you need to be concerned, and things you would try to see, and like in this part of the mechanical ventilation, what would you do?
So the first, so we'll take a step back. So remember, in ventilation, we need to set goals. And the way that we sort of teach it to our fellows and attendings who take this course that I'm a part of, we have the goals of ventilation and the goals of oxygenation that you might have like seen me sort of talk about before. So the goals of ventilation start with, we try to keep the pH around 7.2, right? We accept permissive hypercapnia in a lot of situations. The only times we don't love permissive hypercapnia is right heart dysfunction, because the right heart doesn't like acidosis. It makes the PVR go higher, all that kind of stuff. And then,
Sure.
head injuries. So it also isn't great for ICP. So besides those two situations, we definitely accept some permissive hypercapnia. Sometimes your patients can't tolerate permissive hypercapnia, right? The pH is like 7.25, but the patient's on 30 of
Very
norepinephrine,
nice.
then they can't, we need to sort of like ventilate them more effectively or do something different. So pH of around 7.2, this permissive hypercapnia situation, that's the first goal. The second goal is, we like to keep the plateau pressure less than 30. We know that through, I don't know, 30 years of ARDS literature that, there's something about this pressure in the chest that people do worse when their plateau pressure is higher. Now we got to think about this though, because in patients who are obese, remember, plateau pressure, also known as alveolar pressure, right? That's made up of three terms when we think about it. The first is the volume, the second is the compliance, the third is the total PEEP. So, more volume will make your plateau pressure go up. Less volume makes your plateau pressure go down. Lower compliance, like ARDS, that makes your plateau pressure go up. If you have auto PEEP, and if you followed me for any amount of time on Instagram, I'm like I try to avoid auto PEEP at all costs. Like I think it's not great. It causes barotrauma, worker breathing, you torture people, etc.
Sure.
But remember, the other with compliance, right? There's another sort of the lung compliance, but there's also the chest wall compliance. So people who are really obese, their chest walls are super heavy. So at for every level of total volume, whether it's 6 cc, 7 cc, 8 cc, whatever you want, their compliance is going to be less because their chest wall is heavier. Now, normally, patients with obesity, I don't know if you've seen like right heart caths in patients who have obesity, they have like really big intrapleural pressure swings, right? To sort of like move the chest off of their lungs. So when they have ARDS, this is like so much worse because when we intubate them, we usually paralyze them at least for some time. So now instead of the patient like sort of doing some of the work of breathing to get their chest wall off of their lungs, they're not doing anything. So now we have to do everything. The problem is, I think, sort of from like management, but also literature wise, when we talk about high PEEP strategies, I don't want to like sort of go round and round, but the right now we have these two very broad categories, low PEEP and high PEEP, right? We think so. ATS, like the American Thoracic Society, and I know there's the Brazilian like critical care society. I don't know the name off the top of my head, but for America, we have the ATS. They put out their ARDS guidelines about 2 years ago at this point, or maybe I think it was in 2022. So I guess that's like 4 years ago.
Mhm.
And they had a conditional recommendation for higher PEEP strategies. Like, what does that mean? 15, 20,
Sure.
100? Like, how much PEEP, is high PEEP? So if you remember the sort of the PEEP studies, so like Love's, Express PEEP, and then there's one more I can't remember. Um, One of the subgroups that did better with higher PEEP was like the obese population, right? Like, and that makes sense because you need more PEEP to sort of like open their airways, and number one, number two, get their chests off of their lungs.
Hmm.
What I'm trying to say is that when we think of plateau pressure in ARDS in the obese patient, even if you have 3 cc's per kg, 4 cc's, really low total volumes, you're going to have a higher plateau pressure for every cc per kg of total volume because the chest wall is less compliant. How do we get around that? And I think we'll talk about that. The last goal of ventilation I'll run through is, no or minimal auto PEEP. I already said auto PEEP is bad. So, when I'm setting the ventilator initially, so let's say we just intubated this patient, they have pneumonia, they're in ARDS, I sort of pick middle of the road setting. So, respiratory rate of 18. I start usually with a total volume of like 7 ml per kg, because remember, the thing that's gonna limit us from dropping the total volume is the acidosis, right? Like, it'd be great if we could just put the patient on 4 cc's per kg and like walk away and go back to the call room, but we can't do that because I don't know what the pH is going to be. So I usually try to pick, a middle of the road respiratory rate, some total volume that's acceptable as far as gas exchange goes. I usually start at 100 of FiO2 just for sort of the heck of it. PEEP wise, I'll start, 5 or 8, somewhere in that range. Then I get a gas. When I get a gas, then I start to think about, okay, do I have enough pH? Meaning, if you get a gas on that, let's say, right, on a rate of 18 and a total volume of, I don't know, let's say just 500 to make it easy. That's a minute ventilation of like, I'll do the math, so because I'm too dumb. That's a minute ventilation of 9, right? Which is like pretty good. I mean, 9 ml per kg is like a little bit higher than normal. They have sepsis, they have ARDS, they need more minute ventilation. They're going to have a higher dead space fraction, right, from their ARDS. So that plays into it. But, if your pH is already at 7.25, like we're really going to need to be very specific about how we move the ventilator. We're going to need to move the rate up as we take the volume down, but we're also going to need to add in PEEP to do that, you know?
Sure, sure. Yeah, it's I think by resuming it, I think it would be like no auto beep and try to check your plateau pressures, and probably obese patients sometimes you maybe tolerate a little bit uh, more in check
Right,
how it's going to be,
right,
and tolerate some acidosis, right? I think
right,
it's
exactly.
when you
The other
can.
thing, yeah.
Yeah. Yep. Go on, go
No,
on.
the other thing I wanted to say, if there's some literature about, oh, or there are not studies, but sort of reviews about patients with obesity. So remember, obesity in of itself is a small airways problem. So if you have asthma, being obese makes your asthma worse because you already have small airway disease, which is asthma, and then you add obesity on top of it. So at every point, your chest wall, if your airways are already small because of your asthma, your chest wall is going to collapse them down. So sometimes you need a little bit of PEEP to sort of open them up and not have this obstructive physiology. So if you're not careful with the PEEP, you can also develop like an obstructive physiology on top of everything else, which like makes things worse. That's all to say that setting PEEP and ARDS in patients with obesity, I think is more difficult than we think because we have to combat number one, the chest wall in of itself, like push the chest wall off the patient. And then number two, the ARDS. So like how much PEEP to sort of move the chest wall, but also how much PEEP to recruit lung and like sort of get back to FRC.
Yeah. Nice, nice. Good. And by going over through monitoring these patients, would you say like, oh, every patient, every obese patient, we're gonna go through like an esophageal catheter, esophageal
Mm,
balloon to check the pleural pressure and to monitor all these guys?
yeah.
Or would you go through like EIT, like the just people know the electrical tomography in the bedside? What would you choose, and why would you choose one of them, or would you choose any of them?
Yeah. I don't have EIT where I'm at currently, but I do have esophageal balloons. The evidence on esophageal balloons is that it's no different than high PEEP strategy, sort of from the EPVENT 2 was the study where they tested esophageal balloons versus the high PEEP table, right?
Hmm.
Um, so we'll take a step back for a second. I don't love the PEEP tables, like the high PEEP, low PEEP table. I don't love the low PEEP, high PEEP tables because it it takes away sort of the monitoring of safety, right? So when we set the ventilator, I get back to the initial goals. One of them is safety. So one of them is I need to make sure my plateau pressure is not more than 30. So what I'm saying is that maybe for the obese patient you'll probably work out because you need more PEEP. So if you had more PEEP it'd probably be fine. But there's patients where it doesn't work out because remember recruiting lung takes time, but de-recruitment is almost immediate. So it takes time to recruit lung. So if I intubate a patient and we put them on 6 ml per kg and they're on 80% of FiO2, right? And that gives me some plateau pressure. Maybe it's like 25 or something or 26. Um, if I went by the PEEP table, I would have to make, if it was 80%, I'd have to make the PEEP like 18. And I don't know what the plateau pressure is going to do when I make the PEEP 18 because the PEEP FiO2 table doesn't take into account the lung mechanics at the time. So that's why I don't love the PEEP FiO2 table. Just put that over there for a second. So I have where I am at currently, I have esophageal balloons. I have access to them. And the respiratory therapists I work with are like great and they want to use esophageal balloons. Not all the intensivists I think are like overly confident or have used esophageal balloons before, so they're a little nervous about using them. I personally love esophageal balloons. It comes with a big caveat because as opposed to EIT, which gives you sort of like a global view of, your heterogeneity of the lung. So like, because EIT, and I don't use it much, so you have to correct me if I'm wrong, but, we sort of strap the belt on them, and then it takes into account all the different regions of the lung where there's like different regional heterogeneity of the PEEP. So, maybe one region needs 10 a PEEP, the other region needs 5 a PEEP, the other region needs 20 a PEEP, who knows, right? And then it
Yeah,
sort of like computes that all together and says, okay, this PEEP number is, what you need to sort of recruit all, you know what I mean? So, and I don't
sure.
get that with esophageal balloon, which I understand. So that's a drawback of esophageal balloon. But I think as a safety monitoring device, I think it's helpful because I know what the pleural pressure is, or I have a pretty good guess about what the pleural, at least, I'm not like wildly over distending the lung because as I said earlier, just in my experience, most of these patients, if you have like real ARDS and they're obese, you're going to be on 15 or more of PEEP. Like it's just what it's going to take to sort of like oxygenate them.
Hmm.
And my rule personally, my rule is when I start to get above 20, I get a little nervous if I'm not able to monitor the safety of like that much PEEP. And some people will say, you can tolerate a higher plateau pressure because we know that it's going to be higher because the patient's obese. They have low chest wall compliance. Like that's fine with me. But where I am currently, I have the ability to monitor the safety with an esophageal balloon. So I asked for an esophageal balloon. The other thing is, remember, when we wake them up, right? And ideally, they'd be sort of participating in breathing as much as they can to protect their diaphragm and not get myotrauma and all that stuff.
Hmm.
With a balloon, you can monitor the pleural pressure swings, right? So if the patient's working too hard to breathe, which then leads into this theory of P silly, sort of this patient, self-induced lung injury, because as they pull down harder on the circuit and get, volume and flow, if they're pulling super hard, they can sort of, regionally inflate portions of the lung over and regionally not inflate as much. And then you get this sort of like, you get the pendulum phenomenon, as we call it. So sort of like regional heterogeneity of the lung. So which then leads to lung damage and more ARDS and et cetera, et cetera. So if I'm in this situation, I'm asking for a balloon. If I had EIT, I would put EIT on certainly. If I
Awesome.
had both, I would do both, honestly, because
Yes.
EIT doesn't give you and you can correct me if I'm wrong, I haven't used it. It doesn't give you that sort of worker breathing number, right? It won't give
Sure.
you like your pleural pressure numbers.
Yeah, yeah, absolutely.
Right.
Uh, so would you use like um, the transpulmonary pressure when you are using the esophageal balloon? Would
Yeah.
you guide with the transpulmonary pressure? So let's say you're giving, um, let's say like 18 a beep, but you
Hmm.
have an inspiratory transpulmonary pressure of 20, and your plateau pressure is like, let's say 35. Would
Right.
you tolerate that? How
Mm.
how far do you go with the transpulmonary pressure? What do you think? Do you think we can use it? What your opinion on that?
Yeah. I think so that I think what you're asking is like this recruitability thing, right? Like how recruitable is the patient? So if I make the PEEP higher, am I going to recruit lung with the same volume, which is going to make my compliance better and make my pressures come down? So oftentimes I find with patients with obesity is that we're under peeping them to some degree. So, as long as my transpulmonary pressures and my plateau pressure. So if I don't have a balloon in, if I don't have a balloon in and I can't get a balloon in or whatever the reason is, then I would tolerate a higher pressure, knowing that I probably need more PEEP and knowing that I might be able to recruit them. I'd be very nervous and I'd be like, I would try to, I would like monitor them for safety and as much as I can and like that kind of thing, right? The other thing is, can I do an um an inflation to recruitment ratio, right? Like sort of do the ratio, see if they have some recruitable lung, like sort of mixed in, and then can I tolerate a higher PEEP and higher pressures in that setting? If I have a balloon in, if I have a balloon in, then I feel pretty comfortable. If I have high pressures, I still might need to recruit the patient, but how sort of safe can I be? If I feel like, and this kind of, it gets back to the bedside and like how the patient's doing and all that kind of stuff. But I would rather, if I had high pressures, if I'm able to take the total volume down, but stay at the same pressure. Because remember, if I have, if I'm on 18 a peep, right? And I'm ventilating with, let's say, 6 ml per kg, and I'm getting, high transpulmonary pressures. How can I make those pressures better instantly? If I drop the volume, they'll get better instantly, right? Because I don't need as much pressure to deliver said volume because the
Sure.
volume is smaller. Now, that gets back to the question, am I tolerating the acidosis? If they're really acidotic, that's hard to do. I can't really drop the volume. Maybe I can make up some volume. Maybe I can make up some minute ventilation with going up on the rate. But then we move into this idea of like mechanical power, right? So one of the terms in mechanical power is the rate. So we can make the volume, and we start to get in trouble with auto peep as well, right? That starts to creep in, especially when our patients, probably for you too, like they have a little bit of COPD mixed in, they have a little bit of like ARDS. So then it's like, I can't really ventilate them quickly because then I start to get auto peep. And remember, that's a goal that I try to avoid is auto peep. So, but anyway, um, yeah. So if I have high transpulmonary pressures on the balloon, I'll either, like, depending on how the patient's doing and what I think, if I think they're recruitable to some degree, I might increase the pressure, tolerate it for a bit, and then reshoot my numbers. If I can't and I have room with my pH, I would just decrease the volume and leave the pressure because remember, the PEEP is the recruiter. So if I decrease the PEEP, then I'm decreasing recruitment. So the idea is to sort of like ventilate enough as you recruit. But if I decrease the PEEP, I'm not going to recruit as much. But this is all the rate limiting step in a lot of this becomes the pH. Because if we can't ventilate the pH, and then they have ARDS and sepsis, and they get AKI, and then they get oliguric, and then they need CRT, and like things really start to fall apart. But the rate limiting step in all this, I think, is the pH. So if I have a tolerable pH, you can drop the volume to whatever you want and have the rate at whatever you want. It's just the pH that I think is the problem.
Good, good. Awesome. No, that's really great discussion. And let's say you're improving your patient, he's getting better, and
Mm,
you are starting to win him. And what would be your concerns during winning this patient? How quick will you go with the PEEP? Uh, be- how would you extubate this patient? Would you
yeah.
use the normal, let's say SPT trials? What would you do?
Yeah, that's a good question. What do you do SBT wise? Like in your practice?
We do we for sure don't do any more like T tubes like
Right.
0 0, let's say.
Which
Uh,
is funny because like Tobin, right, who made our Risby score, he thinks that we should all be using T pieces for SBT trials, which I think is really funny because I think most of us have 5/5 pressure support, five, like 8/5 seems like a little bit too much. But
mhm.
I think most of us do like maybe 5/5 type, like in that sort of range, which Tobin didn't think because I don't know if you heard, he did a podcast about a month ago with Critical Care Scenarios, which is they're they're in they're two physician assistants that have a podcast, Brandon and Brian. They're really good. They're super smart. Um, but Tobin was on and he talked about SBTs, and his research like shows that even if you have the patient on a little bit of PEEP, that helps them a lot with work of breathing. So
Interesting.
his perspective is the patient shouldn't be doing any work. Should be the patient should be doing all of the work of breathing. Personally, I think that I would I err on the side of maybe giving a little bit more pressure to help liberate them from the ventilator. because I'd rather get the endotracheal tube out if I could earlier, and I'd rather gamble a little bit with some people that might get intubated, like reintubated, because as you know, every day we're on the ventilator is just more complications, right? So,
Sure, sure.
our fictional patient comes in, he has pneumonia from, from the community, but now he has MRSA pneumonia from being intubated for, an extra 2 days. So personally, so getting back to the patient who has obesity, um, usually, the last patient that I had um, that had ARDS that was obese, right? This was probably about like maybe a month ago, something like that. He had he had an upper respiratory tract infection and then got Haemophilus influenza on top of it and had pneumonia. So we intubated him. He was on like 100%. He's satting like 93. So, I sort of worked the PEEP up. I decreased the volume and I got to a PEEP of about 14 and I had a driving pressure of 12, which I was pretty happy with at that point in time. And his gases got better. He got down to like 60% 60% FiO2. And his P to F his P to F was about like 250-ish. So still like mild ARDS, but like, much better. So we
Mm-hmm.
dropped the balloon and from the balloon pressures, he needed 17 of PEEP
Oh,
by the transpulmonary pressure and by the end expiratory pressure. So on 14, his end expiratory pressure was like -2. So he needed about 17, which got him to like 0. And then his pleural pressure was like 14 or something. It was good. And then his transpulmonary pressure was like less than 15. So it was much better. I came in the next day and he was on 40% of FiO2. So it went from 60 to 40. So what I'll usually do is I'll usually work down the percent FiO2 first. Then I'll start to walk the PEEP down. If I go from 17 to like 15 or 14 and they drop off their oxygenation, I mean, I think it's pretty clear like they've de-recruited to some degree, right? So I have to sort of like go up. But if I could do that, I'll walk down the PEEP by 2 to 3 over a day. So each day I'll sort of walk it down, unless they're like tremendously better and I can like walk it down quickly. And some patients are different. Like they have really bad pneumonia. It takes time for the ARDS to get better, blah, blah. Um, I'll walk down from my highest point by 2 to 3 over 24-hour period. Once I get to a PEEP of like 10, I start to get a little more aggressive. So I'll drop it to 8 or 5, depending if they're really doing well. And then I'll start to SBT them. In the midst of this, I start waking them up as well, right? To see how they sort of interact with the ventilator. Um, for the obese patient, I really, it's difficult because if I can get the obese patient on like 8 over 5, like looking good, I usually extubate them to non-invasive to sort of like,
nice.
and sorry, and I know the evidence is not great. Like I know the evidence is doesn't have this like very strong opinion for non-invasive versus high flow nasal cannula.
Mm-hmm.
I have to be honest with you. Most of these patients should probably be on non-invasive ventilation anyway, like at home, because they have sleep apnea or they have obesity hypoventilation syndrome. So
Sure.
for me, after their ARDS where they almost died, I kind of feel like, at least non-invasive for a few hours um, is better. I don't have evidence to support that. So if you said, listen, the evidence says there's no difference, I can't disagree with that. Um, and then usually if I can get them on non-invasive for a few hours and they look comfortable, I'll usually transition over to high flow and then maybe do that for a day or two or for like a day. And then I'll see how they do. Some patients do great and they don't need the high flow and they really don't need the non-invasive. Some patients like the first night I'll extubate them to non-invasive. We'll do that for a few hours. I'll go to high flow. Then at night I'll pop them back on non-invasive just to sleep. Then the next day I'll really try to like work all that stuff off.
Good, good.
And that's just my approach. There's a lot of everyone's different and some patients like are much worse when you take the tube out and they like need more support for a bit. Some patients you take the tube out and they're great, right? So it really depends on the patient.
Yeah, I really agree with you with that. Like, I really think we need to try, uh, to take off these patients as soon as we can
Yeah.
off the ventilator. And uh, totally agree that, non-invasive, comparing to high flow. Probably we don't have this literature, but like you said, these patients, I think they uh, go, directed to non-invasive ventilation, and give them some pressure for sure to, you know let's say, to make it easier also to them
Yeah.
to be out of the ventilator. Good, good, awesome. I think we went through a lot with this type of patient, with the obese patients. Let's change a little bit, and let's say we are now in front of 6 years old, heavy smoker, with the diagnosis of COPD, gets with new exacerbation, gets intubated. So let's say in this scenario, what are specific points you would be concerned by ventilating them, uh, maybe the first hours or first days? What would be cautious, and would be trying to monitor, and then also how would you ventilate these guys?
Yeah. So good question. And so there's a couple things tomorrow. There's a couple questions. When you have someone with COPD, um, the hospital that you're at or where people are, does everyone sort of go on a like a regimented sort of amount of ml per kg? Meaning, do you always have patients on 6 ml per kg or 7 ml per kg? Like no matter what, is there like a protocol that you have, or it doesn't really matter that much?
Well, I would say that it really depends where you are.
Hmm.
It depends. Some places, the RTs, they have specific protocols,
Got it.
uh, but everywhere I think you can really discuss. I don't really see people being really strict with the 6 ml per kg.
Right.
Uh, and in this type of population specifically, I think uh, we are getting more, I would say, tolerating more, a little bit more volumes
Yeah.
with this
Right.
type of
Good.
patients.
Yeah. And that's and I feel the same way. And I think, in America to some degree, and I don't know if it's the same in Brazil or in other places, but some centers are really kind of like really strict with the 6 ml per kg. Like when they intubate patients, it's like we need to do 6 ml per kg for lung protection from the
Mhm.
vent, right? So there's nothing to like really support that. There's a few studies. The one like prevent, I think, is one that comes up in my mind with patients who don't have ARDS, and you have 6 ml per kg versus anything else, and there's really no difference. But that's not the question here. The question is like in patients with obstructive lung disease, like, how do our goals change? So I still have the same goals, right? Especially the goals of ventilation, which is pH of 7.2, plateau pressure less than 30, and no auto PEEP. The specific thing that happens with patients with COPD is that if they have really bad emphysema, you can give them a volume of 10 ml per kg, and you're not going to be anywhere close to their a compliant or a plateau pressure of 30, right? Because their compliance is
Sure.
so good, it's so high. What happens is, and this is how they breathe normally, right? They take a big breath in and then they breathe out very slowly, and then take another big breath in and then they breathe out very slowly. So we need to mimic that on the ventilator. So when we intubate a patient with COPD, there's two things. The first thing is that remember, because of their emphysema, they have a higher dead space fraction to begin with. So to maintain a normal minute ventilation, they're going to need a higher number because half of that is lost to dead space, right? So they're going to if your and mine minute ventilation now is like 7 or something, right? 6 or 7, depending on your sex and how tall you are and what you're doing. A patient with COPD, I found, they need something closer to like 8, 9, 10. So if they need a 9-liter minute ventilation, and you say everyone needs to be on 6 cc's per kg for whatever reason, you're going to need to make their rate 25 or higher. They're almost certainly going to auto peep with that for sure,
Sure.
right? And like I talked about earlier, avoiding auto peep is like a tenet in mechanical ventilation, the way that we teach it, because auto peep does nothing but introduce harm into the equation, right? It puts you at risk for barotrauma, it puts you at risk for worker breathing issues. It feels like torture for the patient. Um, puts you at risk for hemodynamic collapse because of increased pressure. I mean, all these things, right? So we try to avoid auto peep at all costs. So if I intubated, especially if I just intubated a patient with COPD, you know, you've probably heard me talk about this at least somewhere before, like getting a time constant and figuring out what rate do they need. Now, if it is COPD, right? Some of the patients, they're going to have varying levels of response to treatment because COPD is irreversible obstruction. So if they get intubated, you can give them all the albuterol you want, but if it's irreversible obstruction, it's not going to reverse, right? So, if I intubate a patient with COPD and I get a time constant and I figure out by the math that they need a rate less than 18, let's say, right? Like less than 18, they're not going to auto peep. Then I'm usually putting them on something like a rate of 16 just to sort of be safe, and a volume of 7 to 8 ml per kg. At that point, I'll get my safety numbers. I'll make sure they're not auto peeping. I'll make sure that their plateau pressure is good, which it usually is because their compliance is so high. And then I'll get a gas and see where we are. The problem is when the patient wakes up, right? So if you don't allow them to take as much breath as they want, sort of, if you restrict them to a smaller breath, then they're going to breathe faster. And as they breathe faster, they get auto peep. And as they get auto peep, they feel like they can't breathe. And then the cycle just goes on and on and on and on and on because they feel like they can't breathe. And then they get anxious because they can't breathe, which they're right. They can't breathe because they have a bunch of auto peep. And then eventually, if you don't sort of break this cycle, what happens? Someone says they're anxious, they're agitated. We need to give them sedation. Then we sedate them, and then you're back to square one. So in these patients, I like pressure control or pressure support the best. So knowing that they're probably going to take a bigger breath, so you can't be, I can't be too nervous about a total volume of 650, 700, right? I mean, it can get that high. I will say when we start to get closer to like 10 ml per kg, I start to get a little nervous just because it is a big breath that they're getting, right? So, what do I do in those situations? I need to think about like sedation, number one. Number two is remember this too. If we usually intubate patients with COPD because they get hypercapnic and then they're altered, right? And then we sort of, have to intubate them. But if they wake up like right away because we ventilate them and then their PCO2 gets like normalized and then they wake up. For me, for SBTs, certainly, right? As long as the patient looks like okay, in air quotes, I will extubate them very aggressively because the ET tube does nothing for the patient with COPD but introduce resistance, right? It's going to make their airway resistance higher because no matter what size ET tube it is, right? 8, 8.5, doesn't matter. It's got to be smaller than their trachea. So it makes their resistance higher.
Sure. Nice, nice. And what about the alternative modes? What is your practice on that? maybe in this type of this of population. I'll
Which
tell you
what modes
that
are you? Which ones are you talking about, or which
let's
ones
say
specifically? I guess.
I'll tell you that here in Brazil, maybe less than 2% of the ICUs you will see people ventilating with, like, let's say a PRV, APRV,
Okay. Okay.
bilevel, PRVC. So
Right.
most of the ICUs you will see like the common ones like PCV, VCV,
Right.
and the spontaneous
Yeah.
mode, spontaneous
So
pressure mode. What
yeah.
what what do you think about that?
Yeah. So I mean, APRV you really can't because a relative to absolute contraindication to APRV is like obstructive lung disease because the whole point with APRV is to generate auto PEEP to sort of recruit lung. And in COPD exacerbation, it's not really the problem. I mean, the problem is that we have too much recruited lung, we have like too much PEEP. So APRV wouldn't be a good mode to use and it'd be dangerous and could definitely it can lead to like more auto PEEP and then barotrauma and that stuff. So APRV certainly not.
Not.
PRVC, so the problem with PRVC is two things. There's a couple problems with it, I guess. So, PRVC is servo. So these are like the adaptive modes. So PRVC is servo's adaptive mode. Auto flow is Drager's adaptive mode. And then VC plus is Puritan Bennett's adaptive mode. And then I forget the name for Hamilton. I think it's like APV, CMV, maybe. But those, so, and then ASV is also sort of like built. ASV from Hamilton is sort of built from an adaptive mode sort of like template, right?
Sure.
So with adaptive modes, what you're telling the ventilator to do is you're telling the ventilator to sort of calculate compliance, right? So the vent will give a couple breaths and then say, okay, I gave 30, like 25 of pressure and I got 500 of volume and my goal is 500 of volume, right? So the vent says to itself, okay, 25 of pressure is enough to get my goal of 500. As the compliance changes, it will go up and down with the volume. So if you have, or up and down with the pressure. So if you have COPD, if it only has to give 20 of pressure, then it'll give 20 to get that volume. The problem with adaptive modes is that it cannot see patient's work of breathing. So if you have a patient with COPD and they're tachypnic, even by a little bit, and they start to generate auto PEEP, remember, auto PEEP worsens compliance, right? Just by the numbers, because you're starting with a higher total PEEP.
Sure.
So when you go to give a breath, you need a higher peak inspiratory pressure. So it worsens your compliance for every amount of auto PEEP. Okay. So if I have emphysema and you intubate me and you put me on PRVC, and let's say I can't breathe more than 16, right? We figured that out by the time constant, right? Now let's say for whatever reason I'm breathing not much more than 16, but let's say I'm breathing like 18 or 20, and I develop auto PEEP, right? So I'm going to start to develop auto PEEP on some breaths. Now this is going to depend on how much the patient's working too, but let's just say the patient's not working like very hard. They're not working hard, right? The vent at some point, they're not going to be able to deliver that same amount of volume because now your compliance has gone down, right?
Mm-hmm.
So what's the vent going to do? The vent's going to pressurize higher to deliver the volume, right? Now, as you start to pressurize more and you start to develop more and more auto PEEP, the vent's going to have to pressurize higher and higher to deliver the volume you want. So essentially, if there's no one watching or the patient's not letting you know in another way, the vent's just going to keep going up and up on the pressure until the limit to deliver the volume. This is why I don't like adaptive modes, is because the ventilator is doing something. The ventilator's doing its algorithm, but the patient is doing something else, right? And then the vent can't see what the patient's doing. So then the vent's doing something, the patient's doing something, the vent's doing something, the patient's doing something. So ultimately, someone's going to get hurt, and it's usually the patient. if the patient has a high work of breathing, right? Now remember, PRVC, autoflow, VC plus, all these modes are pressure controlled modes, right? So the flow is not fixed. So if I have a high work of breathing on these modes, I can get more volume. What the vent sees is the vent's like, wow, I don't need to pressurize as high to deliver the volume of 500. So it's going to decrease the pressure, right? As the patient works harder and harder. So now the patient's working very hard on the ventilator and it's not getting support from the ventilator because the vent thinks that the compliance is so good, so it doesn't need to pressurize high. So as the work of breathing of the patient goes up, the support from the ventilator goes down, which is exactly the opposite of what you want on the ventilator, right? I mean, you want the ventilator to do the work of breathing for the patient. That's the whole point we intubate people. So
Sure.
I don't like adaptive modes for, I mean, a number of reasons. The first, I always get the question like, well, what if they're paralyzed, or what if they're like, I don't know, they're in a nursing home or something. Like that's fine, right? If they're not interacting with the ventilator and you want to put them on PRVC, then be my guest. If you look back at the evidence, right? There was one study from from 1999, I think. So the peak airway pressure in PRVC was 20. The peak airway pressure in volume control constant flow, not decelerating flow, constant flow, which is already going to give you a higher peak, right?
Sure.
The peak airway pressure in constant flow volume control was 24. So I always hear there's, peak airway pressure is better in PRVC. I mean, is there a clinical like benefit to 4 centimeters of water of peak airway pressure? I mean, right? It's not
Sure.
like it's 20 and like 100. It's 20 versus 24. But with adaptive mode, you're adding in all this extra unknown because the ventilator is just doing whatever it thinks it should do based off of its algorithm. Now, the one sort of alternative mode that could be helpful in this scenario is Nava. Do you have Nava
No.
or like no, not yeah? Do you know what I'm talking
Well,
like Nava? You know what I mean? Or no?
yeah, yeah. No,
Yeah,
it's not really amazing for, even for, I think maybe for winning. It probably has
right,
some truth.
exactly. And yeah, so Nava is helpful because it'll see how much work the patient's doing. So Nava is the opposite of adaptive modes, right? As the patient's work or breathing goes up, the ventilator support will go up because the point is to offload the work or breathing of the patient. Now, the issue with NAVA, maybe not the issue, but like, you have to be, NAVA is going to pressurize like in response to the patient. So it might go up to a higher peak airway pressure than you're used to or you're comfortable with or something. But that's because NAVA is sensing how much work the patient's doing based on the diaphragmatic electrical activity and then supplying support. So NAVA is like what you want the vent to do. You want it to
Sure.
pressurize more when the patient has more work of breathing.
Mhm.
The other mode that's like that is PAV, like proportional assist ventilation on Puritan
Sure.
Bennett's. I haven't used PAV much because I don't have Puritan Bennett's, but it's sort of the same thing. There's a couple of caveats with PAV because you have to set up like a proportion of how much work you want the vent to do versus the patient. There's there was some evidence for PAV and weaning. There was a study from New England Journal from like maybe 6 months
Last
ago,
year?
8 months ago, last year,
Yeah.
something like that.
Yeah. Yeah.
That pressure support versus PAV, there's no difference, which is like not a surprise because critical
Sure.
care medicine can't seem to set up a trial to like show a difference. I don't use PAV personally because I don't have Puritan Bennett's. I do have I have servos, so I do use balloons, which balloons could be also helpful in weaning patients, especially with COPD, because you could see the pleural pressure swings. Um, or Nava if I have access to it, which at the current moment I don't, but I'm told that we're getting it. So, if like everything else, right? If you know how to use the tool, I think it's useful. If you don't know how to use the tool, then it's just something else that we're using and we don't know what to do with. So,
Good. 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 Interesting. Interesting. Yeah. I mean, as here in Brazil, you will barely see someone using adaptive modes or whatever.
right. Is that
Pretty
just out of habit, you think, or
Yeah, yeah, out of habit. I think also the evidence, I think, didn't
there's
really
not much?
show something that we
Sure.
gotta go through it. anyway. But let's say here different than the other case. Here you intubated, you tried everything. You are with high doses of bronchodilators or like everything you can there. What are the things you think when you are in a refractory patient? He's not responding to the common strategies. Let's say little more PEEP. He's not responding. Already on corticoids
For COPD.
for COPD.
I mean, for the
What would you
problem,
do?
so for COPD, so I think that's the point, right? Is like, is it reversible? So if it's not reversible, so I guess the question is like, what are some things that make me think it's reversible, right? Like to some degree. So if
Sure.
if I don't have a resistance problem, right? Like if my peak airway pressure is only 20, like whatever, I don't know, 20, 21, 25, but my compliance is so high, which is then making my time constant so long, then it's a compliance issue. And if the patient has emphysema, can I reverse the compliance issue? I can't, right? So this is when I start to talk to the family about, intubating patients with COPD is like never a great thing to do, right? Because COPD by definition is like an irreversible lung damage, right? I can't fix it. I can't wait it out. If I have a patient with COPD that has high airway pressures and I think it's resistance problem, that makes me think maybe they have some bronchospasm that I need to wait out. So I'll wait. I'll just wait. I usually for I don't know how in your practice, but for me, if we get to the point of intubating a patient with asthma, um, you know, we're usually I use it usually takes how long? 4 days, 5 days, a week for them to get better. I mean, it could take a long time. So
Sure. Sure.
I usually start to tell the family that like, this could be asthma, this is COPD. We're going to need to wait some time, right? 4, 5, 6 days. If we get to that point, and there's so if we get to that point, so for me personally, I check the time constant. Like that's something that really guides my practice because if the time constant's still long by day 7, we could wean the patient, right? We could try a spontaneous breathing trial, but what's going to happen as soon as they start spontaneously breathing? They're going to get auto peep. Then they're going to get agitated. Their volumes are going to drop off. They're going to look terrible, and then they're going to fail. But I already knew that because their time constant was already long. Like I already knew that.
Mm-hmm.
So if I have a patient that has high airway pressures that I think is more sort of bronchoconstriction, I'll give them time. If I get to some number of days, 5, 6, 7 days, and I don't think we're getting any better, um, that's when I have a conversation with the family. And sometimes I don't know what to do. Maybe we wait a little bit longer. We need to think about does the patient want a tracheostomy, what that would look like what their goals are. So that's important.
Good.
If I intubate a patient with COPD, and their area pressures are like normal or low, but their compliance is very high, right? Like 70, let's say, is like their dynamic compliance. Like that's a compliance issue. I'm not going to fix that with steroids, antibiotics, bronchodilators.
Sure.
So, I get a number, right? Usually their time constant, like their inspiratory time, they can breathe somewhere between 16 to 20 if I'm lucky. So when I do the SBT, I really, really try to give them enough support to make sure their rate goes less than to make sure their rate is less than what they'd start auto peeping at. Does that make sense?
Sure.
So
Sure.
if they're on like, let's say 12/5 of an SBT and they look comfortable, they're breathing 15 and their total volumes are like 500 or something, I'll extubate them and put them on BiPAP and then try to sort of wean the BiPAP over, a day or two because that's the best they're going to be on the ventilator, right? And the ventilator, like we said before, does nothing but adds, it just is complications, pneumonia, um, like DVT, immobility, diaphragmatic injury, and then, you know, like the patient coughs, and then somebody thinks that they're agitated, so then they get sedated, then they get antipsychotics and all this stuff. So I think it's better for the patients with COPD if we don't think they're going to get any better. if you have some number that you try to stay under as far as the respiratory rate goes, which is what I do, I'll figure out the time constant. And if I say to myself, they have to breathe less than 18, then they got to breathe less than 18, no matter what that takes. If that's more pressure support, that's what I do. If they're sort of awake and alert and their breathing looks okay, but they're on more pressure, but this is the best that I'm going to get based on their compliance number, I just take the tube out. And then I tell the family, I say, we take the tube out, they might do well, they might not do well, we might have to reintubate them, and then that's a question for them. Like, and putting patients with COPD on the ventilator, like with a tracheostomy, it's terrible, right? Like they don't do well. They still can't breathe fast, right? They still can't breathe more than their time constant. So I really worked the time constant into the COPD equation, into the COPD sort of population, because if they just have a compliance issue, that's going to tell me exactly what they can't breathe faster than. And honestly, I've had patients who can't breathe more than like 12 on the ventilator. And I told the family that. I said, by the numbers that I see, he can't breathe more than 12 times per minute. And that's going to be really hard to do with the tube in, right? Because they get anxious, they're coughing, it's uncomfortable. So I just wind up, I keep hitting the table, sorry. I just wind up taking the tube out, like pretty aggressively if I can, because I know getting the tube out is probably going to help them the most.
Good, good. Interesting. I thought was really interesting this approach of looking to the time constant and differentiating what is the problem. It's really really nice.
Well, you know what the servo is, that if you have servo, right?
Sure, we have.
Yeah. If you on the servo right, if you go to the screen where it gives you the plateau pressure and the total PEEP, it'll give you the time constant there, because it just takes the resistance and the compliance and it multiplies it and it gives you a number. So if the patient, if you do an inspiratory hold and an expiratory hold and you let the ventilator calculate the numbers and the patient's passive or paralyzed, that time constant's like pretty accurate. So, if your time constant's like 1 second, right, and you need 3 of them, so you need 3 seconds for exhalation, and you make, your inspiratory time 1 second, so then each breath cycle is 4 seconds.
Sure.
Like, 4 divided by 60 is 15, right? So they can't breathe any faster than 15 or they're going to auto PEEP. It's just like, it's just math, right? So for me, when I do that, I get the time constant, like I look at it every day, because, if it's 1 on day 1 and then on day 2, it's like 0.5, they've gotten much better. Wow. Like the time constant's improved, I can start to wean them. But if it's continually 1, right, if it's still showing me they're obstructed and they have COPD and I don't think it's a resistance problem, then the only thing that's left is a compliance problem. And I can't fix that. It's irreversible. So
Sure. And what would you do when the patient is in spontaneous mode? How would you calculate this?
the time constant, yeah, that's a good question. I know, that's a wonderful question. You can't calculate it if they're sort of spontaneously breathing. That's when I start to look for the flow and sort of the other markers of auto PEEP, right? So if the flow doesn't get back to the baseline, if there's difference in area under the curves, if they have ineffective triggers, right? The biggest cause of ineffective trigger is auto PEEP. So you're not able to calculate the time constant because spontaneous breathing doesn't make the calculation accurate from the ventilator anymore. You can, if you have an esophageal balloon in, you can get auto PEEP from the balloon, right? You can sort of like calculate it from that. You can see how much they're working. So that's where a balloon is helpful in that situation as well. But if they're in spontaneous mode, so that's the question though, right? If I got the time constant in the beginning of their intubation, and I think this is all COPD and it hasn't changed, when I put them in spontaneous mode, I'm not going to make the pressure support 5 because they're not going to get a big enough volume, right? They want a bigger volume. Sure. So I'll increase the pressure support to 8 or 10. And if they're on 10 over 5 and they're breathing comfortably and it's COPD, I'll pull the tube out, right? And then just try to support them with BiPAP. But this is where you have to make sure the family knows and even the patient knows, like, this isn't something that I can fix. This is something that we might be able to titrate the BiPAP off, but ultimately this is like an irreversible condition. So if they don't do well, we might need to reintubate them. But like then you're talking about in the life. You know what I mean?
Sure, sure.
Yeah.
Oh, that's really great. Thank you. Uh, One last question that
Yeah.
actually didn't send you before, but
Yeah.
really wanted to know what are the your opinion on the perspectives of mechanical ventilation. How do you think AI will change our practice? Uh, Speaking about mechanical ventilation, do you think we're gonna be more outside of the bed, or do you think it's gonna be just just another device to help us?
I think I do think that it's going to be another device to help us, because unless there's like some other thing, right, that can that can it be a lot of monitoring, because the vent screens are woefully under recognized for worker breathing, for desynchrony, for um like amount of time in desynchrony. I think when you put like these vent screens into these large language models, what it shows is that a lot of the times, like the patient, like what we have set on the ventilator is, either over or under supporting the patient just sort of out of the gate. So I think that's where AI can help us, is identifying desynchrony, and then maybe, is it going to get to a point where it identifies a desynchrony and then it
Right.
can sort of like adapt to it? I think that would be helpful. I still think there's going to be a place for the bedside clinician, because there's still this like work of breathing perspective that just the ventilator screen can't always give you, if can't always sort of give you. Now, if the AI gets so sophisticated that's like sort of reading all the waveforms, and you put in the resistance of the tube, and then you put in the size of the patient and maybe their characteristics, can it get to that level? I guess it can. Because when it comes down to it, these things are just it's and not that I'm good at math, but it's more or less just math, right? You
Sure,
need a
sure.
certain amount of pressure to generate a certain amount of flow to get a certain volume over a certain time. So I'm sure if you gave the ventilator or the AI all of the variables, it could calculate exactly what it needs to sort of like deliver the volume, right? I think the where the clinician comes in is that there is going to be some nuance with the ventilator in the different disease situations, right? The different disease scenarios. The ventilator still, and I think from like in Dreger, where you have like ATC, like the tube compensation, there's still this kind of like thought or theory or point with the vent is still, no matter how fast we're able to deliver flow and volume, it's like still a certain amount of percentage behind the patient of like what they want, right? So there's still going to be a place for the clinician, I think, to really dial in settings or manage the ventilator, maybe in conjunction with AI, who knows, in really sick people for whatever that's worth, right? But I think for patients who are intubated for whatever reason, um, let's say it's like a neurologic injury, or let's say it's like for altered mental status or something, AI could be a really powerful tool, because, and this mostly is because we're really bad at reading the ventilator screen, right? So the patient's got, premature cycle, delayed cycle, like whatever dysynchrony they have, and we can't recognize it on the screen. Whereas AI is going to be able to recognize and say, and maybe alert you and say, hey, this patient's been in the late cycle for 12 hours, consider shortening the eye time or something, right? Like that would, I think, would be super helpful. I would like to think that there's still a place for us in all of this. I'm not, I mean, maybe, who knows? Maybe if it gets like really sophisticated and you give the ventilator all the variables and monitoring software, we're not going to need to do that, because this just comes down to math. We get back to the equation of motion. You want a certain volume or a certain pressure. If you want to set a certain pressure to get a certain volume, or you want a certain volume so that you tell the ventilator to generate a certain pressure, that's all it is. So it just comes down to math. And AI can certainly do that faster than we can. So I think that's going to be something to look out for.
Sure. How far are you guys in this in the US?
AI wise, like for the vent,
Yeah.
um, to be honest with you, I'm not sure. I know there's a bunch of studies that, or there's at least a couple where they've downloaded like a lot of, like days and days worth of waveforms and have calculated and have the like sort of fed it to a large language model, and it's spit out like how much time the patient was in desynchrony, how many desynchronies there were. um as far as like monitoring, I don't know where they are with that. I do know, um that's another use of AI, but I don't know why. Is Brazil, do you guys have like AI
No, no,
software,
nothing,
like looking at, yeah, nothing like
nothing
that yet.
going on. No, no,
I
nothing
mean,
going.
the other, it's so hard to, all this software stuff is like so expensive too. I mean, for esophageal balloon manometry for the servos, it's like another, it's another thing they have to buy sort of from servo, like the software for it. It's
Sure,
like thousands of dollars. So even if some AI company comes up with it, it's going to be hard because they're really going to have to demonstrate that there are some cost savings, I think, to installing the software onto the ventilator, right? I mean, sure, it's great for safety monitoring, but if it doesn't really decrease their mechanical ventilator length of stay by some days, and like we're already pretty good. I mean, we're already like of 3, 4, 5 days, right? We already have like pretty good mechanical ventilator length of stay just by doing the stuff that we should be doing, which is like liberating from sedatives and all that kind of stuff. So
yeah,
I don't know if this is going to be any more than just like an academic thing. Um, I think it'd be helpful, certainly for safety, right, for the patient and for comfort. But I don't know. I don't know where it's going to find its niche, I guess, is my question.
well, good, good. So, think we discussed a lot of things.
Yeah,
I
man.
really want, yeah. Thank you so much for this time, Nick. It was great. If you want to end it up with any message, share anything, any of your works and your Instagram, it's open to you.
Oh yeah. Yeah. So find me on Instagram at Palm Toilet, PULMTOILET. I have a podcast. It's not as successful as your podcast, but it's sort of like a little bit more niche. It's called the Peak Inspiration Podcast, where I just have been kind of working through ventilator topics, kind of like every other week, sort of is like where I'm at this point. Um, I've been teaching the ventilator to fellows for, and like a couple attendings for about like 2, 3 years now.
Nice.
It's one of the most it's like one of the most misunderstood things that we use in the ICU. It's one of the things that can really contribute to like certainly torture and death for the patient if we don't use it correctly. Which is why, I started teaching this stuff like on Instagram, because Instagram has a pretty far reach, right? So like
Yeah.
worldwide, right? So which is why, and I promise I'll answer every message I get on Instagram if people reach out with questions. If you're confused about a topic or there's like a waveform, certainly if you have something that's going on clinically, you take a picture of the waveform, we can always talk about it. So I try to be pretty, like reachable by that. So please reach out anytime. Love to talk about this stuff. So
Okay. Thank you so much. Thank you.
yeah, man. I appreciate it,
Okay,
dude.
guys. Thank you. That was it. Uh, we'll see you later. Thanks. Bye bye.